Good morning, everyone. Thank you for having me in this nice 7th Saudi Spine Society meeting. Today, I'll give you a brief on my thinking about lateral approach and XLIFs. By talking about XLIF, we do a lateral position surgery for the patient. It's a retroperitoneal transpsoas approach. And usually, this is marketed as sparing for the back muscles, bones, and ligaments. And you have to have really very important to have the neuromonitoring when you do these surgeries. So this is the retractor that I use, and this is the monitoring that I see during this XLIF procedure. So we simplify goals of us as surgeons when we operate on the lumbar spine. We want to decompress the nerve roots, cauda equina. We want to restore sagittal balance and correct deformities. We want to achieve a successful fusion, but we also want to prevent complications and nowadays affordable treatment for the patient and the third-party payer. So our options when we operate on the lumbar spine for interbody fusions are ALIF, as we just heard, TLIF, which is very common in Saudi Arabia, PLIF, and then lateral approach, which includes OLIF or DLIF or XLIF. So doing an XLIF, my thought process is that it helps me in doing indirect decompression without going posteriorly. And this study will give you a nice way of thinking which patients can you do indirect decompression and which patients you need to go and do a TLIF in these patients. Pimente looked at what happens to the patient with indirect decompression in the MRI findings. And there was significant increase in the disc height, foraminal area, and central canal diameter when you do a big cage in the middle. And this is the MRI pre and post XLIF with indirect decompression of the nerve root, the central canal, and the foraminal height. So there is some things. The problem with this is that can be affected by subsidence or loss of reduction. So you have to pick your patients and you have to do the procedure and not expect subsidence. Fusion rate is a very important thing in spine surgery, and my gold standard is an ALIF for the best fusion. The problem with ALIF in this country is not very popularized, maybe the big centers, but we don't have access surgeons available, and we're not comfortable doing anterior body fusion. So I had to find something that resembles the fusion of ALIF, but it's done more simpler. This is also looking at the sagittal balance, comparing to ALIF and XLIF. And XLIF and ALIF have a good correction of the sagittal balance and lumbar lordosis and foraminal height. Foraminal height, you can see this is one of my intraoperative x-rays. When you do a lateral approach, you put the cage, you can see significant benefit in terms of foraminal height and reduction in terms of decompression, indirect decompression. So I can feel that in the OR, I can see it, and I'm happy with this kind of specific patients. End plate preparation is very important when we're doing any kind of interbody procedure. And it's very important to not damage the end plate because that would increase your subsidence. So the XLIF has good access to the end plate. You can do excellent removal of the disc and preparation without end plate damage. If you look at the footprints and effect of subsidence and fusion rate, this is the 4 procedures that we use. And I think using an XLIF, you can use or have a good footprint, similar to the ALIF, maybe bigger because it goes beyond the end plates. This is a study looking at spanning of the lateral interbody cage across the vertebral ring apophysis and how it affects the failure and migration of mitigation of the end plate and causing subsidence. So when we look at all these lateral cages put in, the cage that had the bigger and spanning the ring apophysis did not violate the end plate had the strongest and less failure rate. This is one of the cases that I revised, and it just gives us a hint of how the difference between a big XLIF cage and a TLIF, and it makes you thinking about subsidence and fusion rates in these small cages. So the complications, if we look at our options in terms of interbody fusion, I think a lot of us are afraid of ALIFs because of the high vascular problems that we encounter or reported. But also the TLIF has a lot of non-unions, implant failures, and cage migrations. So there is complications with both of them. The concern of XLIF was a lot of the previous studies saying that there is significant neurological compromise. And most of them, I think, is technique related. Having transient weakness of the hip flexors is something I can see, but it usually disappears within 6 weeks to 12 weeks. So the challenges I find in doing Saudi patients, and where I find XLIF very helpful, is the obese patients. So when we have obese patients, we have problems with x-rays, we have higher rate of dural tears, anesthesia complications in the prone position, and wound complications, and deep vein thrombosis and pulmonary embolism. So when I see my patient like this in the OR and I'm planning to do a posterior approach, I know I made the wrong decision to this patient. And the report shows that there's about a triple risk of posterior wound complications when you do a posterior open on obesity patients. So I want to give my patients less risk of having problems. So maybe if I put the patient on the side, that fat that I'm seeing posteriorly will disappear or fall front, and then I can do a better procedure. When we compare a complication with minimal invasive transfemoral interbody fusions and lateral approach, the complications is more of wound complications in the TLIF than the XLIF, but there is also issues with transient neurological and weakness in the hip flexors. This is a 2-year outcome study comparing MIS lateral approach and TLIF, where there was significant changes in the hip flexors, 30% of the patients with XLIF, but nothing in the TLIF. But this was also transient. It wasn't, and there was no significant difference in blood loss or operative time. So just going through my thinking, when I see a patient with a 1-level spondylolisthesis and his MRI doesn't show central stenosis, this in my mind is a good candidate for XLIF. And when I see a patient who has a spondylolisthesis, but in the MRI there is significant stenosis and the psoas is like teardrop, this will give me also problems when I do a lateral approach. I go to a TLIF. And if the patient is fat, it's usually minimal invasive TLIF. And if the patient is thin, an open TLIF does the job. So this is a patient of mine that had 2 previous discectomies, came back with severe leg pain again, and she was thin. Her BMI was 25. So in this case, in my hands, an open TLIF would make a good approach for this patient since she's not obese. If this patient, if the patient before had this kind of a body habit, I would probably prefer to do a tube type of approach and try to decompress from the back and put an open TLIF. Case 1, just to summarize my thought thinking. 43-year-old female presented with chronic lower back radiculopathy. She denies history of low back pain, and she failed conservative treatment. This is her x-rays. She has a grade 1-2 spondylolisthesis, and her MRI axial images does not show any central stenosis. So you can appreciate the instability, and her radiculopathy is coming from the formal stenosis with the listhesis. And she's a little in the heavy side. So in this patient, I would prefer to do an open, a percutaneous screws with an XLIF. And this was, when I started, I would do a lateral approach and then flip the patient. And then things changed a little bit. This is another patient, 34-year-old female. She had mild lower back pain, but she had severe radiculopathy, more than L3, and her BMI was high. And we discussed this case, me and Anwar Habib, do we do anything for L4-5, or we just treat listhesis and the radiculopathy? We discussed it with the patient, and she agreed with doing only a minimal invasive approach. So we ended up doing a lateral XLIF approach with a cage and a plate, 1 incision. The patient did well, followed with me. She has no more radiculopathy. She might have problems in the back pain in the future, but up to now, there's nothing hearing from her. This is the 3rd case that I can show you guys. This is a patient who came from Jeddah. She had surgery in the spine about 10 years ago in Germany, L4 to S1 fusion. She started to develop some radiculopathy on the right side, and her axial MRI revealed a decent level disease with a cyst there causing compression. So my thoughts, she's a little in the overweight size, she had her vision, so doing a smaller surgery for her would be appropriate. I discussed it with her, and we ended up doing an XLIF with a plate, and then a tube decompression at the right foraminal area. She's now about 4 weeks. We'll see what happens, but hopefully her initial presentation in the clinic, her leg pain is gone. So it is a hassle doing an XLIF and then flipping the patient and doing posterior percutaneous screws. This is a study that's showing there is evidence that we can save, with the big cages, we can save doing fixation both sides. So nowadays, I'm doing something a little different. This is a patient who had a discectomy, continued to have ridiculous symptoms. You can appreciate that he doesn't have any central stenosis. He has retrolisthesis and collapse of the disc. So an interbody fusion would help this patient in terms of the leg pain. So this patient, I decided to do a unilateral approach, which a prone position, do an XLIF, and then in the prone position, shoot percutaneous screws as it's one position. And it takes less time in the OR, save us also in terms of cost of the implants. And just going through the last thing in this, looking at XLIFs and TLIFs with unilateral and bilateral pedicle screws. An XLIF with unilateral pedicle screw is equivalent to a TLIF with bilateral pedicle screw in terms of stress on the rod. And I think there could be more changes in terms of lateral approach, big cages with less fixation. So my perfect patient for XLIF is a patient who's obese, who has maybe a grade 1 spondy, disc degeneration with foraminal stenosis, previous instrumented fusion with adjacent level disease. He has to have no central stenosis, and preferably not a smoker, and no osteoporosis or osteopenia. I usually do the first visit, I do BMDs for my patients, and I start them on, with the help of endocrine on Forteo or Affinity to treat metabolic bone disease. I think it saves us a lot of problems in the future. Thank you very much.
Thank you very much, Dr. Anwar.